So this is a 52-year-old patient with diabetes. Vision so far is pretty good at 20/30 OU, and on the exam they kind of noticed this. So the first question I posed was, if this is a left or a right photo, how should they answer this, or how would they describe this photo in kind of a succinct and complete way?
Sounds good. Thanks, Ramin. So, this is a right eye, and it's a right eye because the optic nerve is located on the nasal side every time. So, this is a fundus photo, a color fundus photo of the right eye. You usually start by describing how the media is. So, I usually start by saying if the media is clear or it's not clear. So, in this case, the media is clear. Then I usually focus on the optic nerve. The optic nerve looks healthy, pink with sharp margins. Then you kind of describe the blood vessels. In this case, the blood vessels look normal. And then you can focus on the macula. In this particular case, you can see that there's some doublet hemorrhages, microaneurysms. The doublet hemorrhages are usually a little bit bigger than the microaneurysms. So you see some that are a little bigger and then some tiny little red spots. Those would be your microaneurysms. And you can see hard exudates, which are those little yellow patches that you see superior-temporal to the macula. They're hard exudates because they're a little bit more yellowish than what a cotton wool spot would be. So these are likely more hard exudates. They're yellowish and refractile, more than cotton wool spots. I noticed that somebody on the answers commented that it looked flat. You can really not comment on a fundus photo if a lesion is flat or not, because you really don't have a 3D, right? This is a 2D image, so you can't really comment on thickness. However, some clues about thickness can be given by the blood vessels that kind of go over the lesion. If you see a bend on those blood vessels, you kind of assume that the lesion is elevated, but that's only if the lesion is really, really elevated. So it's kind of hard to comment on fundus photography if a lesion is flat or not.
And so if we have this patient come in our clinic, we usually grab OCTs of the macula for a lot of our retina patients. Which one of these would you expect to find, in this particular patient with diabetes that you've been following for a while? So this kind of options would be this top OCT versus this bottom OCT here.
Alrighty, sure. It'd be the bottom one. I guess the one that has the B on it. You see the hard exudates, which are those little refractile whitish spots that you see within the retina. So hard exudates will be inside the retina. On the top picture, what you're seeing is drusen. Some of them can be drusenoid PEDs just based on the size of the drusen, but you see them at the level of the RPE. So hard exudates are within the retina, drusen are under the RPE.
And I've always considered kind of hard exudates as possible evidence of prior edema. And so that kind of tells me that this ring here is from old, kind of dried up edema, leaving behind all these deposits. Is that correct to think, or?
Yeah, I mean, I guess you can have hard exudates both in active and old edema. Sometimes you can have it with active thickening as well, kind of surrounding the active leakage. But sometimes it can be kind of old. And as you describe, how it looks kind of roundish, those hard exudates on the picture above. So those are usually called circinate exudates. And most of the time, those circinate exudates will encase a little bit of fluid inside. But again, sometimes it's already flat, and those lipid deposits, the hard exudates, can last for years. So it's hard to assess if it's acute or chronic just based on the exudates.
And then based on just the picture, if you didn't have the history at all, does kind of the color and refractile nature let you know that it's a hard exudate, or not necessarily use like drusenoid pictures, or is that not necessarily always true?
I would say when they're refractile and yellowish, they tend to be more hard exudates, but it is a little bit hard, especially on a 2D image, because you can't really tell how deep in the retina they are. On exam, it'd be a little easier because you can tell that drusen are under the retina and hard exudates are within the retina when you use your 90 diopter or your 78 diopter lens. But in a 2D image, it can be a little bit hard, especially if it doesn't have that circinate, kind of shape. When it's circinate like that, you kind of always think of exudates, but if they were a little bit more diffuse, sometimes it can be hard to tell if it's drusen or hard exudates.
Okay. And then obviously the history is playing a big role here too for this question set. But let's say this patient's coming back with completely or vision's like really decreased down to 2400 now, and we're taking another OCT, but now their OCT is looking quite different. So I wanted them to describe, essentially try to replicate what they would type out in their note. So what would a good note description of this OCT look like in a succinct, what would you want them to write out?
Sure. So I think the way I would describe this OCT would be presence of intraretinal fluid and subretinal fluid with adjacent hard exudates. And you see distortion of the ellipsoid line right under the fovea. I noticed that some people were writing cystic spaces, which it's a good description, but as Dr. Pulido mentioned, I'm not sure if the interns were on that imaging conference or not. Cystoid spaces would be a better description. Usually cysts, by definition, would have like a little layer that encases them, and that's not true for this case. So I would stay away from calling these cystic spaces. You can call them cystoid spaces or intraretinal fluid, which is a little bit wider descriptor that works well anytime you see any kind of fluid inside the retina.
Okay. And then contrasting this patient to this next one, kind of have these like more flat appearing yellow lesions. Flatter in color, not necessarily in the retina itself. And then I'm given some demographic information too. What do you think of this eye compared to the diabetic eye that we saw, or patient with diabetes in the previous photo?
Sure. So, I guess a few things to note is this is a left eye as opposed to the previous patient with the right eye. And again, you can see that because the optic nerve is on the nasal side, or, kind of, and it's nasal because the macula is always going to be, temporal and down. So that kind of gives you a little bit of orientation there. But as you mentioned, it's not as refractile. They're more kind of dull in color. So it looks more like drusen, and obviously being an 83-year-old patient, you cannot lean towards going with macular degeneration a little bit more than anything else.
And then some of the answers did focus on whether to start ARED vitamins or not on this one. I think everyone got, the description and diagnosis kind of spot on. What are your thoughts on starting AREDs?
Yeah, so I think it was an open-ended question on what would you do. I guess I wasn't sure if you were asking for other testing or like what would you do as far as treatment. Some of the interns or PGY1s mentioned, getting an OCT, which is absolutely right. Something to keep in mind. Sometimes you can get an IVFA on these patients to make sure that you're not missing any early CNVM or an OCTA. Those are good testing options as well. As far as AREDS vitamins, I do start my patients on AREDS vitamins if they have intermediate stage macular degeneration or more severe forms. Usually I would not start them if they're early. But in this case, those drusen definitely look like they're on the intermediate or large sizes. So I would start the patient on AREDS 2. One thing to keep in mind is if the patient is a former smoker, you would want to make sure that the AREDS formulation that you recommend to the patient doesn't have beta carotene. So you would go with either AREDS 2, because the AREDS 2 formulation doesn't have beta carotene, or you can use there's some AREDS formulation, which is the earlier formulation that can be bought without beta carotene.
And then as far as, the patient, like subjective complaints that they might call you about and want to get an earlier visit, are there any, subjective complaints that they might say to you that make you worried about progression or anything else like that?
Yeah, I think one of and some of the PGY1s also mentioned giving the patient an Amsler grid. So I think it's important for a patient to self-monitor at home with Amsler grid. There's, 10% of patients with dry macular degeneration that can switch to wet at any time. So I think it's important for them to check Amsler grid weekly. And what I tell them is to make sure that they check one eye at a time, because sometimes some of the metamorphopsia that you can get with wet macular degeneration is sort of camouflaged by the good eye. So I always tell them once a week, make sure you look at that Amsler grid one eye at a time. And if you notice any changes, please give me a call. I'll get you in right away. So metamorphopsia would be one of the ones that I would be really worried about, and I would like to get that patient in right away.
And are you having them do this vision test kind of up near, or is it far away, or does that matter?
Usually, I have them do it up near, and I tell them to use their reading glasses if they usually use reading glasses for near. And again, either just put a tissue uh, inside one of the lenses so they're only looking with one eye, or kind of close one eye and close the other, and do it at near. They can also put it on the refrigerator or by the mirror in their bathroom. I think those are two places where, they're always kind of looking at it, and that will remind them to do it. And they usually will stand kind of near to look at them in that situation as well.
So I kind of paired these up as things people can compare. So this is comparing AMD versus the diabetic eye. Now we're going to move on to this one. We'll compare these next two patients together or with each other.
Mm-hmm.
So this one is an elderly 86-year-old male with glaucoma and hypertension, and then experiences a non-painful loss of vision, and he's count fingers in this left eye. So what do you think about if you saw this on your exam, Dr. Reinoso?
Yeah, I mean, usually if you see the amount of hemorrhages that we're seeing here, the amount of intraretinal hemorrhages, and a few of them being flame hemorrhages, which is that shape where it's kind of an elongated type hemorrhage, I would think more of a vein occlusion. And in this case, since you're seeing it in all quadrants, it's likely a central retinal vein occlusion.
So this patient, with this current appearance and this current presentation and everything, would they need PRP or any treatment?
No, I mean, it does. He doesn't seem to have any vascularization of the disc or elsewhere. Although it's not a wide field photograph, but just from what I'm seeing here, without neovascularization, I wouldn't consider PRP. I may consider an IVFA, just to see the amount of ischemia and the risk of neovascularization.
And so, speaking of which, so let's say this patient's lost to follow-up, and then they come to the ED with severe eye pain, headaches, and blurry vision. And you look at their eye and they see this.
Yeah. So I know, in a bunch of the questions or the answers, they were mentioning PRP, which is a good option. The issue with PRP is it will take a little while to work. PRP takes a few weeks to start working. This is a more kind of emergent situation where you have those abnormal blood vessels that are blocking the trabecular meshwork, and that's why you likely have NVG with elevated intraocular pressure. So Avastin is something that I would consider right away. Avastin makes abnormal blood vessels kind of regress very fast. And you always have to tell your patient when you do this, it's hard to know if the Avastin alone will help with the pressure, because if they've had NVA for a long time, they can create synechia. And at that point, even if the blood vessels regress, the scar tissue will still be present, and the intraocular pressure may not go down. But you do try to give Avastin as soon as you can to try and prevent that synechia, try to get that pressure to go down. Most of the time you would have to do an AC tap to try and make the pressure go down if it's too high, and then you give the intravitreal Avastin. You may want to wait a little bit for the eye to quiet down, especially if they have corneal edema, to be able to perform your PRP. But if the patient is doing okay and the cornea is not cloudy, you can actually perform PRP at the same time that you perform Avastin. I noticed that one of the interns mentioned that you would hold off on PRP if the patient had macular edema. It's not the case here. It's more the case in diabetes, but not really with CRVO, because it's a more emergent situation. You just want to treat both things.
Okay. And that's if you were doing, if you were trying to do Avastin and PRP at the same time, or would you hold off on it? Or?
Either way. I mean, I think for diabetes, it's more important to hold off on PRP and treat the macular edema first. Mm-hmm. For CRVOs, it's a little bit different. If you have neovascularization, you want to treat with PRP and likely Avastin as well. But you wouldn't wait to treat the fluid. You want to treat with PRP pretty quickly.
So if you had, let's say, if I give you two scenarios here, the mm-hmm. first one is, a patient with very good transportation, very reliable, and is going to come into every single appointment, can make it day or night. What would be the ideal strategy that you would like to do for this patient?
Sure. And they have clear cornea, or they don't have clear cornea?
Clear cornea.
Clear cornea. Okay. I mean, I would ask if they would like to do both things at the same visit, and if they do, I would probably start with the PRP first, and then do the Avastin injection right after. You don't If you're gonna do both at the same time, you likely would want to do your laser first, then your Avastin, because you don't want to mess with the injection site after you've done your Avastin injection. Um, if the patient says, I just want to, if they're nervous or if they just want to do one, I would start with the Avastin because that's what's going to make the vascularization regress a little bit faster. And then we'll bring them back in a week or two to get PRP.
And you did mention that the response can be quite rapid. Would you expect these neovascular the NVI to pull back by that week?
Yes, yes. It usually goes away in a couple of days. Actually, it's pretty fast.
Okay. And then let's say the next patient now we have a lot younger of a patient, 42-year-old, previously healthy, comes to ED with sudden non-painful loss of vision. What do you think about this one?
Yeah, so I mean, again, you see those flame hemorrhages, which are those elongated hemorrhage, but you're only seeing it over the superior temporal quadrant. So this goes more with a branch renal vein occlusion.
And then anything about like the age between the two cases here?
Yeah, I mean, the first patient had a lot of risk factors for an RVO, right? They were hypertensive, diabetes, old patient, glaucoma. This patient doesn't really have any of those risk factors. So this is someone that I would do lab work on and make sure that I rule out any hypercoagulable state.
And then kind of tangent to that, not vessels, but we're kind of moving into a different kind of obstruction here. But it's an 83-year-old patient who also has a particular history with PMR or polymyalgia rheumatica, has some headaches, also has diabetes and hypertension, and comes in with this finding on their fundus exam.
Yeah, so I would describe this picture as a fundus photo of the right eye with clear media. The optic nerve margins may look a little bit hazy, especially inferiorly and superiorly. When you look at the blood vessels, some of them seem to be very attenuated. Hard to see if there's any box carrying there or not. The whole retina looks kind of whitish, likely edematous, with sparing of the fovea and the papillomacular bundle. So this is likely a CRAO with maybe a ciliorenal artery sparing.
Okay. And then what would you want to order for, say, your CRAO patients?
Or so especially in these cases, yes, if the patient is 83, I would definitely order an ESR and a CRP to rule out GA, especially with the history of headaches. But I would also, in any patient that comes in with CRAO, you want to make sure that it's not an embolic event. So I would also get carotid ultrasound, a 2D echo or a transesophageal echo. And if this patient comes through the emergency room, like this patient did, I may probably just call in the stroke protocol and kind of get all that rolling. If it's a little bit more chronic, if they come in with symptoms for a month, I may do the workup as an outpatient. But if they come through the AED with acute symptoms, I'd probably just kind of do everything in-house.
Okay. So I guess a couple of things with this one. I think of CRAO as a diagnosis of like the state of the eye. All it's saying is that the artery's occluded, but it's not telling us etiology at all. So like you said, it could be a number of things. So GCA is not, mutually exclusive from a CRAO. It can cause a CRAO. Likewise, like you're saying, embolic events can also do that. And then the other thing that comes up, people talk about like cherry red spot. So in this case, we don't necessarily see that. And you mentioned the cilioretinal artery. Can you kind of describe the difference of those two and why this looks so different?
Sure. So some people may have a cilioretinal artery. It's not it's actually uncommon to have a cilioretinal artery. So most people will not have it, and when they get a CRAO, the whole retina would be edematous. But since the fovea is so thin out and doesn't have RNFL, the RNFL doesn't get edematous over the fovea, and that's why you still see the fovea as a red spot, which is the typical cherry red spot kind of picture that you can see on typical CRAOs. When you have that ciliary artery, it basically irrigates that papillomacular bundle extending into the fovea, and usually doesn't come from the retinal artery. So it would still be pain even in the when you have a ciliary artery occlusion. And another thing to keep in mind is you wouldn't see a cherry red spot if you have an ophthalmic artery occlusion, because at that point your choroid is not going to be irrigated either. So you wouldn't see that orange hue that you typically see in CRAOs on the fovea.
So if I'm understanding you correctly, you're saying the cherry red spot or this nice darker area is actually not changed. This is the normal appearance. We're just seeing the choroid, but this paleness out here is the change. It's from the ischemia and edema. That's making
Correct.
it pallorous, but this is normal appearance.
Correct. Correct. And that edema is usually from the inner retina, because that's what is irrigated by the central artery. So you would see edema of the RNFL on OCT.
I see. And then you said if the blockage was further back, such that the choroid also isn't getting fed, then we'd lose that color as well.
Correct.
Okay. And then another thing that comes up quite often is trying to stage our patients with diabetes or diabetic retinopathy. And the 4-2-1 rule kind of comes about quite a bit from residents to the interns, just kind of going over that.
Sure. I mean, I would say that for me, the classification of non-proliferative diabetic retinopathy, usually it's mild when you just see a few microaneurysms. Moderate when you see more microaneurysms and you start seeing dot blood hemorrhages, which again are just a little bit bigger than microaneurysms. And then severe when you have the 4-2-1 rule. 4-2-1 rule is 4 quadrants of diffuse dot blood hemorrhages. So it's not just regular dot blood hemorrhages. If you see dot blood hemorrhages in all 4 quadrants, if it's just like 2 dot blood hemorrhages in each quadrant and they're not diffuse, that wouldn't be severe, that would be moderate. But if you start seeing these diffuse, which look like big patches of hemorrhage, and by big I mean like a quarter disc diameter or maybe even a little less. But when they're not just dull blood hemorrhages, but more diffuse patches, and they're in the 4 quadrants, then that would be the 4, which would make it severe. 2 is venous beading, which looks like little engorgements of the veins. So the veins will start looking like little patches that are a little thicker and then thinner and then thicker and they're thinner. That's the venous beading. And if you see that in 2 quadrants, then that would make it severe. Or if you see any ERMA, which kind of look like these little lacy blood vessels, and you can differentiate them from neovascularization because they don't go into the vitreous, right? So they're flat on the retina, but they don't look normal. You can see these little kind of lacy little blood vessels, but again, they're in the retina still. They're not kind of breaking into the vitreous. Any of those patches would be ERMA and would make it severe.
Okay. And then this next part is kind of some rapid fire application of 4-2-1 rule and then other diabetic, stages too. Mild, moderate, the 4-2-1 rule, and then going also into, when they get proliferative. So, each section you just get one little bit of information. You try to fill out the rest. So if you saw a patient with just 2 microaneurysms in the macula, how would you stage that?
I would call that mild, and I would follow up in 9 months.
And anything to do at that visit?
Just I would probably get an OCT since the MAs are right in the macula, just to make sure they're not leaking, but just kind of check vision and make sure it hasn't progressed.
And then, correct me if I'm wrong, but for this next one, I have moderate here. And my understanding was, according for the standardized photos, that even a single dot blot hemorrhage might push you into this.
Yeah, I mean, by definition, if you start getting dot blots and not just MAs, that should make it moderate.
Does that change your follow-up or plan at all?
Yeah, when they're moderate, I usually follow them every 6 months.
Okay. And still nothing to do, just keep monitoring and making sure that they're controlling their sugars and pressures and everything with the PCV.
Correct.
So next one is a patient that's 20/20, has a couple dot blots, has some MAs, and they're flat, but you see NVI on the left eye.
No, that would make it proliferative.
even
So
though they
once you
don't
have any,
have any of this other stuff?
yeah, I mean, in my view, anytime you get neovascularization, that makes it proliferative.
And then anything to do or follow up here?
I would actually inject that patient
Hmm.
and laser them and follow up really closely.
So
I
pretty.
treat it as
Oh,
as sorry, I would say I would treat that as high risk PDR.
so
Once they get NVI, that's bad
mhm.
news.
So pretty similar treatment to the CRVO with NVI case, kind of minus those special cases with how you think of the edema. But it seems like once you have NVI, there's kind of a protocol where you want to try to aggressively knock out the VEGF and prevent it from coming back.
100%.
Okay. And now this is one where I think a lot of people kind of jump to the definitions and don't necessarily refer to like the standardized photos, but it's, let's say you see just a single dot blot in all four quadrants. What would you stage this one?
I mean, if it's not diffuse blood hemorrhage, I would call it moderate.
So it's not just four quadrants filled up. It's you're seeing a bunch of dot blots in each quadrant, correct?
And it's more the severe, the diffuse nature of it.
I see.
So if it's just a dot blood where it's just pinpoint,
Hmm.
that doesn't make it severe. It has to be diffuse dot blood hemorrhages.
And then nothing special is just the same thing as our moderate for
Yeah,
follow-ups and plan.
correct. Hmm.
Now let's say we have NVE near the arcade and a large cystic intraretinal fluid space on the OCT. Where would we put them, and when should they follow up, and what should be our plan there? Does it differ at all from the neovascularization in a different location?
Yeah, I mean, I would call this proliferative, but it's not high risk. So I would just there are different ways of doing this and different ways of thinking, and some retina specialists would treat this as PDR, and once they see neovascularization, they would go full blown PRP or Avastin. I do it a little bit different in that if they're not high risk, I may just watch them, especially if the patient is reliable. Now, if they're not reliable, I would probably treat. Um, but if it's a small patch of NV, I may just watch him. If the cystic space is central and affecting vision, I would probably inject.
Okay. Now, this is a patient that might be a little further along, maybe had some intraretinal bleeds and everything, but right now in their current visit, not a single dot blot, and then they have this 360 endo laser with PRP, and then kind of a questionable spot with maybe some lacy vessels that not quite sure if it's IRMA versus NVE,
Mm-hmm.
and has not had any injections in the last 4 months and has been pretty quiet, other than this one spot that's kind
Okay.
of concerning.
Alrighty. I mean, for this patient, for me, once they're proliferative, they're always proliferative. So I would call this proliferative diabetic retinopathy status post PRP. Um, what I would do is get an IVFA to try to determine if this is truly active NVE or IRMA. IRMA would not leak. NVE does leak. Um, if on exam I have any doubts, again, mostly on exam you can tell if it's IRMA or NVE. But if they are not bleeding and everything looks stable, I may just watch them and kind of take up those photos every so often to make sure that those abnormal blood vessels are not enlarging.
And then this last one, it's a patient with just MAs, but then they have the center involving DME.
Mm-hmm.
What do you take in that? Do you include, the macular edema in your staging, or is it separate from that? And how do you handle a situation where kind of a little more asymmetric in terms of the intraretinal bleeds and the edema presented?
Sure. I mean, you can have macular edema at any stage of diabetic retinopathy. So that really doesn't bump it up. Having macular edema doesn't bump it up from mild to moderate or moderate to severe. You can have mild with CME or without CSME, or you can have moderate with CSME or without CSME. So it doesn't really change the classification of the diabetic retinopathy per se, but you do want to follow those patients closer. So if it's central involving, you're going to treat and you may likely see them every month if you're injecting. If it's not central involving, you're going to follow them every 3 months, regardless of if it's mild, moderate, or severe. You're going to see them at least every 6 months. 3 months, sorry.
And then kind of going more on the diabetic cases, there's a moderate non-proliferative diabetic retinopathy that you're following in clinic and they've been doing really well. Let's say they barely have anything, in terms of fundus findings, but then they come to the ED with a history of kind of some floaters, and now it's kind of, vision's kind of gone out, not completely, but it's pretty dark for them. They can only make out maybe fingers, and you look through and there's a faint glimpse of the nerve, but everything else kind of has this diffuse red haze.
All right. So I guess the question is, you saw that patient recently and he was moderate, it wasn't proliferative?
Correct.
All right. So, I mean, the main cause of vitreous hemorrhage is diabetes, diabetic retinopathy. So that's the main etiology of vitreous hemorrhage, but there can be some other etiologies of vitreous hemorrhage, right? So you would have to make sure you rule out those other etiologies before you say, okay, this is likely diabetic, I'm going to start injecting. Or I'm going to wait a little bit to see if it clears on its own. The main thing you want to make sure is that this is not a PVD, a hemorrhagic PVD. So you would like to B-scan that patient to rule out any tears or retinal detachment. Make sure there's no, if you're planning on injecting, you want to make sure that there's no tractional retinal detachment that can crunch with those injections. Make sure that the patient doesn't have a history of trauma, and this is not a traumatic vitreous hemorrhage. But if you roll those things out, and the patient wants treatment and they want to get their vision back quickly, then you can offer them an intravitreal injection. If the patient is a little scared of injections, you can wait a little bit and see if that blood clears on its own. Just ask them to keep the head elevated, see if that blood settles down a little bit, which is actually sometimes nice to do, especially if you're not really sure what the etiology is. If they're hypertensive, this could be a rupture RAM, a renal macroaneurysm. So again, some things you may just kind of choose to watch for a little bit and see what happens before you start putting needles in someone's eye. But if it's a monocular patient known to have vitreous hemorrhages, then that's kind of a different deal.
And so, I mean, you mentioned kind of the different ways you think of vitreous hemorrhage in the monocular patient. Sorry, let me back up. So non-clearing, like if the vitreous hemorrhage doesn't clear after a few months, what would be the plan?
I mean, at that point, you would probably start thinking about a vitrectomy. You do want the vitreous hemorrhage to clear, not only to make the vision better, and for you to see the retina a little bit better, but also because if you leave blood in there for too long, that's when you start forming all those membranes, right? So you want to prevent a tractional retinal detachment. You want that blood to clear.
And if we're thinking that this vitreous hemorrhage is from kind of some vascularization, would doing PRP in this case be a good idea right then and there?
Yeah. If we think this was diabetic, then we would do a PPP with endo laser, kind of do that 360 laser and hopefully prevent future bleeds.
But right away, like in the clinic, while they're still, kind of having this vitreous hemorrhage, and if you can't get a view, would that make it pretty hard to do the PRP?
Very hard.
Kind of
correct.
In clinic?
So you're 100%. So your option there would be either to wait and allow that blood to settle, or inject to try and make the view better for you to be able to perform that panretinal photocoagulation.
And you mentioned monocularity. Are there any other reasons why you might want to go in and clear it earlier? Any other findings or things that would make you?
I mean, if you're suspecting a tear on V-scan, then you would probably want to go in and clear it a little faster to be able to laser around that tear and prevent retinal detachment.
I see. And then the other thing that I've seen come up is someone that's very quiet like this. They might have a vitreous hemorrhage and then it clears, and then someone decides to do an IVFA and it looks like they have florid diabetes, but on our fundus exam they only had a couple dot blots and wasn't terribly impressive, but they did have a lot of dropout of their vessels. Does that come up?
Yeah, that can happen sometimes where especially if it's peripheral ischemia, sometimes you can miss that peripheral neovascularization. So IVFA can sometimes be very, very helpful. Again, you can't really do it when they have an eye full of blood, but if that blood goes away, it'd be a really good idea to perform an IVFA and see the amount of ischemia and the amount of neovascularization. And it can also guide you to see exactly what areas you would like to laser.
I see. And so, speaking of floaters, the next patient comes in with kind of something they're describing as black spider webs coming across their vision, and they come to the ED in the middle of the night. What
Mhm.
would you want to do here?
So you want to do a dilated exam, a full dilated exam. The few things that I always look for when a patient is complaining of floaters is at slit lamp, I want to look at the vitreous and make sure that I don't see any pigmented cells. If I see any pigmented cells, that kind of worries me a little bit more because then I know that this could be either a tear or those could be red blood cells, and he may be having a hemorrhagic PVD or some other form of mild vitreous hemorrhage. Um, the other thing that you want to look for is white blood cells, because actually vitritis can also give you floaters. So
Hmm.
if you see white blood cells and vitritis, that's also something to look for. So in patients that are seeing floaters, the slit lamp exam of the vitreous is actually very, very important because it can clue you to where you need to look. And after I do that, then I do a very full exam, including a scleral depressed exam to make sure that I'm not seeing any holes or tears. I look with my 90 at slit lamp 2 to see if there's a PVD. I go back to the previous notes to see if the patient had a PVD or not, because that can guide you a little bit more into what is the etiology of the floaters. Um, I sometimes get an optos if there's availability to get optos fundus photo, and you would like to do just central optos and then superior inferior fields. That gives you a better and wider view of the retina. And I would always get an autofluorescence as well if there's capability of doing autofluorescence, because some some of the white dot syndromes can give you floaters and flashes. And usually in autofluorescence, it would kind of bring up those choroidal lesions. So that's how I approach it is, good slit lamp exam, good exam with your 90, and then a good peripheral exam looking for vasculitis or looking for holes or tears or traction from a PVD.
And so, if you do an exam on this patient and there's no cells in the vitreous, the retina looks nice and flat without any tears or holes anywhere, and you notice kind of the vitreous detaching around the optic nerve,
Mhm.
what would be your next step there? Do we have to do anything? Do we have to take that out? Do they need to be referred to retina?
So at this point, I mean, if you feel pretty confident and everything looks good, you can either elect to send to Retina or you can just watch them on your own. Give them return or retinal detachment precautions, worsening of floaters, flashes of light, a veil over the vision. And I would follow this patient up in 4 weeks because they're not out of the woods yet. The vitreous starts detaching at the very posterior edge by the optic nerve, and then it kind of goes forward. And when it starts detaching anterior, there's still a chance you can get holes or tears there. So you want to watch that patient closely, bring them back in 4 weeks, and make sure once that vitreous is fully detached, you don't see any holes or tears.
In the 4 weeks, so you're saying there's kind of some tighter points where the vitreous is attaching and it's kind of progressive, and 4 weeks is roughly where it starts pulling the posterior end and starting to cause troubles for us.
Usually before that, it usually starts within a week or two. That vitreous should be completely detached, maybe 3 weeks at the most. So that's why you see them at 4 weeks, is because at that point it should be completely detached, and hopefully at that point, if they don't have holes or breaks, the chance of getting one is pretty low.
And then you mentioned if they have a hemorrhage with their PVD, that would put them at higher risk.
It puts them at high risk of finding a hole or a tear. Correct. So you have to look really, really well. And again, if you can get a really good exam, then that's a patient that I would refer to right now.
The last thing here is, we do utilize the B scan quite often in the ED if we can't get a great exam, or if the media is opacified for some reason, we can't
Mm-hmm.
do a great job with that. How would we differentiate, a detachment that might be retinal versus attachment of just the vitreous?
All right. So usually, if you have a posterior vitreous detachment, there are a few things that would differentiate. One is you wouldn't see an attachment to the optic nerve. So when you have a retinal detachment, the retina may be detached all over, but you would see it go right towards the optic nerve and kind of meet at the optic nerve. In a posterior vitreous detachment, you'll see that posterior vitreous is actually detached. So it may spike a little bit, and you may see a little bit of a hyperreflective line moving around, but it would be separated from the optic nerve. The way they move is also a little bit different in a posterior vitreous detachment. If you have the patient look around, what we call a kinetic exam on B scan, and if you have them look around while you have the probe, you'll see that that whole vitreous kind of swirls around quite a bit, while the retinal detachment usually doesn't move that much. And the spike that you get on A scan can also be a difference. Usually you get 100% spike, a pretty tall spike, if it's a retinal detachment, while if you're just seeing that hyaloid, the posterior vitreous is encapsulated by the hyaloid. So when it detaches, you see the hyaloid floating around, and that's what can be misleading into thinking it's a retinal detachment. That hyaloid spike is not 100%, it's usually a little shorter.
I see. And this last question I have here, I think seeing this on the OCT kind of terrified me the first time I saw it. So I was just hoping to kind of get your thinking on this. It's a patient with kind of some mild asymmetry in their cup to disc ratio, so you decided to do a lot of these tests, and somehow you ended up getting an OCT MAC without necessarily any indication, but it came back with this.
All right. So yeah, if you see the hyaloid, so that's the hyaloid that's being attached right at the fovea there. We call this vitreomacular traction. So when it's pulling up on the fovea and it's distorting the foveal contour, you call that vitreomacular traction. If you just see it that's adherent to the fovea, but it's not pulling and you still see a good foveal contour, that would be vitreomacular adhesion. When you have vitreomacular traction, you kind of want to monitor them a little bit closer. If it's not visually significant, in this case, the patient is 20/20, you really won't do anything but just watch him. You tell the patient, there's a chance he'll pull away and everything goes back to normal. There's a chance it just stays like this forever, but your vision is excellent and we'll keep an eye on it. Or there's a chance he'll keep pulling and bring the retina even higher up, destroying your vision, in which case we can offer surgery. Or if it pulls too much and creates a full thickness macular hole, then we would go to surgery as well. In this case, I usually give my patients Amsler grids as well. And I follow them initially kind of closely, maybe 3 months. And if everything's stable at 3 months, then I space to 4. And if it's stable at 4, then I see them every 6 months.
I see. And so those are some of the, kind of often seen in clinic things, or things that confused me at some point that I thought would be good for them. But I'd like to open up the floor to you and see if there's anything that you think residents miss, or maybe don't quite understand, that would be helpful for the rising first years to get a grasp of before they start.
Oh no, I think you did great with this. Diabetic retinopathy is one of the things we see more often. So knowing how to classify it, knowing how to differentiate CSME versus DME. It's also important for OCAP questions. Clinically, a little bit less relevant now that we have the OCT and we can just simply say it's affecting the center or not, and then we treat accordingly. CRVOs we see quite often, especially because we see a lot of patients with glaucoma because of our population here in New Orleans and Louisiana, really. GCA, really important to diagnose and treat, because it can be blinding and it can affect the other eye. So it's really important to diagnose and treat, as you mentioned. So I think these are all very, very important things. CRAOs, we'll probably chat with the interns a little bit more when we chat about emergencies early in July. Knowing, I saw that in your lecture you had posted the OCT and the layers. Really important to know which layer is which. That will help you differentiate between different pathologies depending on what layer of the OCT or the retina is affected. But I think you did a great job. I can't really add anything else. This is great.
All right. Perfect. Thanks for your time, Dr. Reinoso.